But in my lifetime, I went from having no idea what this was to this thing coming to the forefront of everyone's mind and US culture right now, which is fentanyl, which is, I believe, one of the, if not the most potent opioid drug that's out there. So why was this developed? What makes it so potent, and why is it doing what it's doing right now?
Yeah, no. So fentanyl is an extremely potent mu-opioid agonist, right? So it activates the mu-opioid receptor at extremely low concentrations, right? So the reason it's so potent is that it requires such a small amount of it to activate the mu-opioid receptor. It just hardly takes any. It was developed as a prescription intravenous use analgesic for surgery, and it's still used in that context, and it works quite well. I think the reason that it's in the vernacular of all of us now, and everyone's heard of fentanyl, is that because it requires such small quantities, and because opioid addiction is such a problem, particularly in North America, the illicit drug providers and the folks in the labs around the world that are making illicit opioids have found that it's much easier to make a little tiny bit of fentanyl and ship it wherever it needs to go around the world to the end user, and then dilute it in something that's not fentanyl and sell it as heroin, right? So whereas a certain quantity of heroin might be fit in a thimble, the same potency quantity of fentanyl might fit on the head of a pin, right?
Wow. So there's an economic drive there. It actually reminds me of the illicit cannabis market, where the economics were such that people wanted to get as much potency into as much matter as possible, because it made it easier to transport this without getting caught.
Right. And it's really problematic. And personally, I think that we've made it worse with the war on drugs and the way we've criminalized people who suffer from addiction, and rather than treating it like a disease and a medical problem that could be solved with medical tools, and we've treated as a criminal act, which it just exacerbates the problem.
Mm-hmm. Why is it so deadly? Is it because it's potent at the mu-opioid receptor?
Well, so the reason all opioids can be deadly is that they act in this pre-Boettinger complex in the brainstem, where they inhibit, they cause respiratory depression. So they slow our breathing, right? So typically what happens, and this is the problem with fentanyl, is, someone who is addicted to opioids, oftentimes, they may have gotten it prescribed by their doctor for legitimate pain, and, begin taking more and more of it also as prescribed, but then find it really difficult to get off, or find that the reward that they get from it, whether it's the euphoria or simply the relief from some emotional or psychological pain that they're experiencing, is enough that they then get addicted to it, right? And as they continue to take it, it works less, and the efficacy diminishes, and they build a tolerance to it. However, you don't tolerize to the respiratory depression, right? So we even see in the clinic, right? So there are patients that even under the supervision of a physician, you'll start to see respiratory depression as they give them higher and higher doses. So it's not necessarily something that is, someone just decided they wanted to get really, really high and take a ton of it, and they overdose. No, I think most often what happens is that people know exactly how much opioid they need to get their fix, whether they're looking for a high or they're simply trying to keep the pain at bay. They know how much they need. They think they're getting a certain formulation. They think they're getting heroin, or they think they're getting morphine or oxycodone, but instead they're getting something that's laced with fentanyl, and it may not be mixed in well, so that one dose of this powder has a lot more fentanyl in it than another dose of this same mixture. And eventually, if you keep elevating the dose, you get to a point where it makes you unconscious, and then you stop breathing. And
I see.
Die, right?
So eventually, if you take enough of an opioid, and it doesn't actually matter which opioid, it just turns out that fentanyl is the most potent, so you don't need that much. Yeah. It just slows down your breathing, and at some point, it stops your breathing.
Yes, that's right.
And you basically just go to sleep, I guess.
Yeah. No, it's tragic and really sad at so many levels, but and it's it's a big problem. With COVID, obviously, we're not hearing about it nearly as much as we did, a few years ago. But actually, during COVID, the number of deaths has really soared. And just this year in I should say it's 2022 now, but in 2021, we just passed 100,000 deaths per year due to opioid overdoses in the U.S.
I think that's actually more than COVID, or am I wrong about that?
So the cumulative COVID deaths in the U.S., I think, are now up in the hundreds of thousands, right? Mm-hmm. But I can say that the opioid deaths, there are more deaths per year in the U.S. from opioid overdose than cardiovascular disease, cancer combined.
So it's near to the top of the number one cause of mortality.
Yes.
Wow.
Yeah.
Another area that I want to ask you about is cannabinoids, because I know there's some overlap here. A lot of people talk about cannabis for chronic pain, and I know there's some interesting synergistic effects that can apparently happen between opioids and cannabinoids, such that perhaps you could take something with THC in it, say, and that would allow you to get the same level of pain relief using a lower dose of your opioid. Do you know anything about what's going on there?
Yeah, I actually don't. I should probably. As you know, in science, a lot of times you get sort of siloed into your little narrow niche, and I know a bit about it, but I don't feel enough to really give too much detail. Other than there certainly is an additive effect, right? Mm-hmm. And there's a real synergy between not only cannabinoids, but a lot of the different analgesics. And the cannabinoids, I like to think of as sort of they change the synaptic signaling between neurons, right? And so they kind of act as a way of fine tuning a lot of different processes, including pain, right? So it's really not terribly surprising that when you take a cannabinoid in addition to any of the other analgesics, that people find it beneficial. Mm-hmm.
What about I imagine that there's a lot of effort to develop novel pain drugs, and I know that you've been involved in this in different ways. Yeah, so, high level, how does this work, generally speaking? And is it possible, to make a novel pain drug that's, say, derived from an opioid, such that it preserves the pain management component, but gets rid of things like the addictive potential or the respiratory depression aspect?
Yeah, no, there's a lot of folks doing interesting work in this space. Myself and a couple guys at Harvard that I was in the lab with started a company, Blue Therapeutics, 5 or 6 years ago, doing this work, and that company is still ongoing and doing some interesting work. One of the ways, before I get into Blue, typically the way that people have gone about trying to develop non-addictive or less addictive opioids is different ways of formulating them, right? So you can imagine that if you make an extended release formulation, right, or something that within the extended release case, you might be able to just take one pill and you have sort of a slower, steady state. And so you don't get the peak in the serum levels that could sort of trigger that euphoria. in theory that works, but in practice, people can just take, if they want to get high from an extended release opioid, they can just take a couple of them and then they're high for a long time, right? And so that's actually what happened with Purdue Pharmaceuticals and the OxyContin, right, which is an extended release oxycodone. So that was the first attempt. A lot of the first attempts were extended release formulations, which really ended up causing more problems than they helped, I think, in a lot of cases. Other ways, other folks have used biased agonism. So, the mu-opioid receptors are G-coupled protein receptors, GPCRs, and you can when you activate a GPCR, there are downstream signaling cascades that are respond to their activation, and you can design molecules that favor one downstream signaling cascade over another, and see some differences in the clinical profile of those. And there are some companies doing that. Other groups have tried to come up with peripherally restricted opioids. So these are drugs that don't enter the brain or the spinal cord, but act only in the periphery, act only in the body, right? On the opioid receptors in the skin and the muscles and whatnot. And those have also shown some limited promise, but in clinical trials haven't worked that well. In my opinion, it's not terribly surprising because chronic pain, which is what is sort of the big bad wolf of the pain space, that's the most difficult to treat and where there's the greatest need. Chronic pain is largely due to central sensitization, and so if the central sensitization is driving the chronic pain and your pain drug is peripherally restricted, it's probably not going to work all that well for chronic pain, right? And so it's going to have a limited use case. But one approach that I think is just the most interesting to me, and like I said, I gave several years of my life to this, is using receptor interactions as a way to target subsets of opioid receptors. So this could be done to target any receptors in the brain or really anywhere in the body. But in the pain, in the opioid space, a guy named Phil Portuguese, who's a medicinal chemist at University of Minnesota, together with Ajay Yakarala, who is a Ph.D. neuroscientist who did his Ph.D. with Phil, they came up with some molecules that activate opioid receptors only when they're interacting with each other, right? And so, for example, I mentioned earlier, there are 3 different types of opioid receptors: mu, kappa, and delta. They are present in different parts of the brain. Some areas they are present together. Other areas, only one or the other will be present. And so Ajay and Phil came up with a way to design molecules that activate these receptors only when they interact. So the one that Blue Therapeutics pursued and still is developing toward the clinic is a drug that acts on mu kappa interactions. So if you have a mu-opioid receptor, which is present in the areas for the reward circuitry, the pain relief circuitry, as well as some of these areas that underlie tolerance and withdrawal. And then you also activate a kappa receptor, which is present in the pain relief circuitry, not present in the reward circuitry, but it is also present in some areas that cause dysphoria and some unwanted effects. But if you can activate only the interaction of those 2 receptors, and only when they come together, you can target certain tissues that have only that express both of those receptors.
Yeah,
right?
It makes sense. So instead of the drug coming in and sort of hitting every possible receptor that it touches, you've now created a drug that, in effect, it's only hitting quite a small subset, I would imagine, of all of the individual opioid receptors.
Right. And in this case, it's hitting the mu kappa interaction that occurs predominantly in the spinal cord circuitry that is responsible for pain relief. And so,
So the hope here, and I imagine this is what they're testing, is you can preserve much or all of the pain management side of things that you get with opioids, while at least lowering the addictive potential or the overdose potential.
Exactly. Right. And they work quite well, right? So Blue Therapeutics has a compound called Blue 181 that is similar in potency to fentanyl, but it does not have respiratory depression. It does not have tolerance. There's no place preference in rodents. And it really, I mean, it looks by all the preclinical measures like sort of the holy grail of pain relief, right? And in that it has this profile where extremely potent, really strong pain relief, no tolerance, no withdrawal. And it's like I said, it's currently being developed, and I was full disclosure a part of that company until about a year ago when I stepped away to pursue these additional technologies in the space with Black Box Bio, where we're developing these assays for screening of additional pain drugs as well as psychedelics and some other compounds.